Thank you for having me. So I'm Alex Trompeter. Sorry I haven't been here all week. I get very anxious about coming to the north. So there we go. So I'm an orthopedic surgeon in London. I'm full-time in trauma and post-trauma limb reconstruction. And I'm going to talk to you about understanding strain. Actually, I'm going to give you a little talk now, which I've changed the title of, to non-union and why has it failed to heal? Because I think if we go to the non-union end of the fracture healing side of things, we can understand better the journey that a fracture needs to go on and the problems it can encounter, and then understand strain as a concept, as a continuum, and we're going to hear a lot about that through the morning and through the rest of the day. So I'm just going to give a couple of acknowledgements, primarily one of my fellowship trainers, David Elliott, for some of his slides, but there's an awful lot of other people, many of whom are in the room, that are responsible for the content of this talk, really. We're going to try and understand the nature of the problem and define it. We're going to reflect on the normal recipe for healing and then the implications of strain theory on that journey. So the first thing I ask is, what is a non-union? And if you Google what is a non-union, you can find a phenomenal definition by the Americans. The FDA will define it, and it gives a temporal period to what a non-union is, and it absolutely stands by it, and this is what you should use if you're going to write a paper on non-unions, and I say that's not right. I think a non-union is bespoke to each individual. It can't have a one-size-fits-all situation. Different bones, different injuries, different physiology, different patients have different non-unions at different times. So it may be that it can be defined in terms of a failure of progression. It may be that you can put a time scale on it. It may be that we're looking at a radiographic definition, a histological definition, a functional definition. To me, a non-union is a bone that isn't going to heal without you doing something. Ultimately, it's that simple. And a delayed union, you just need to wait a bit longer. And the nuance and the art of clinical practice in non-union management is that you've got to judge the difference between sometimes a delayed union and a non-union. And we don't always get it right. And if you have a long enough waiting list, some of your non-unions will have joined up by the time the operation comes to be. So it would just very briefly reflect, because this is coming up again later, there are in my mind, four principal etiologies, the four I's that can cause a non-union. To me, it's the instability, it's the mechanical side of things, the strain element that I think we should focus on first and foremost. Just to refresh our memories, this is the typical teaching of non-union from a radiographic classification. And primarily, we're interested in the vascular group. So that's the Weber and Czech vital non-unions. And you'll be familiar with this, the hypertrophic, the oligotrophic, the atrophic non-union. So these are the radiographic appearances. And I want you to remember that, the radiographic appearances of non-unions. Avital, to me, if there's dead bone in there, once you've removed that, that is a bone defect. That is no longer a non-union. It is a different clinical entity. And the traditional teaching will tell us that a hypertrophic non-union is vascular and it's got good callus and it just needs that little nudge of stability. And then you go all the way to the other end of the spectrum, and an atrophic non-union is avascular and it must be bone grafted. Just keep that in the back of your head. So let's go to normal bone healing and normal biology and understand strain along that journey. So I ask you, why does this heal? Not how does it heal, but why does it heal? And the answer is because we are genetically predisposed to heal our skeletons. If you can't heal, then from an evolutionary perspective, you can't hunt, you can't reproduce, you're essentially not useful. So you couldn't go and hunt your woolly mammoth. And in modern days, that turns into us not having function. You can't work, you can't play sports, you can't have a family, etc., etc. And if you don't believe me that we're not genetically predisposed to heal, please go and visit this phenomenal building. It's in a little town called London in the south of England. This is the Natural History Museum, probably the most beautiful building in London. And if you hunt around in the Natural History Museum, you will see this. This is the metatarsal of a dinosaur, and there is a lump of callus in the middle of that, and it has healed. So bone, since it appeared on the evolutionary circuit, has had a genetic propensity to heal. We, as orthopedic surgeons, can only interfere with that. We'd like to think that we are responsible for bone healing, but actually, all we can do is influence the journey that the bone heals on. But the genetics for healing are there all the time. And that is from that complex interplay between these cells, the osteoblasts and osteoclasts, through their signaling cascades and all these chemicals that you'll have heard of. And ultimately, we end up with two principal requirements for bone healing: the biology and the mechanics. And this is where we're going to delve a bit deeper into strain. If you think of a fracture as a contained organ, okay? So we have something when you break your bone called the bone healing organ, and that is formed from the initial hematoma and then all the cells and so on, and the whole tissue environment from bone and all the surrounding soft tissues in the fracture site. Then that bone healing organ is influenced by things that maybe impede its formation, so open fractures where the hematoma falls on the roadside or the soft tissues are stripped or damaged, or the performance of the organ, i.e. the smoking that may impact on the blood supply to the area, but also stability. Why does stability influence the bone healing organ? Because the tissue that is developed by the bone healing organ is dependent on the strain environment within. And this is ultimately Stefan Perren's strain theory. What do we mean by a favorable mechanical environment? Well, stability is inversely proportional to strain. So we know that the mathematical formula for strain is the change in length over the original unit length. Okay? Let's try and understand that a bit more. How stiff do we want to get? What is that magic number in bone healing? There must be something we can quantify and define. Well, it's just right. That's what we need to get to, just right. And it's impossible to actually measure individualized strain at a clinical level in our patients, depending on our soft tissues, the fracture, the size of the fracture gap, the implants we're using. There are too many variables. We can measure it in a lab to some extent, but in day-to-day clinical practice, it's very difficult. But ultimately, if we remember that the tissue in the bone healing organ is defined in terms of its genesis by the amount of strain that occurs locally, then we can use that knowledge in our clinical practice to influence our fixation constructs and in the management of non-union. The amount of movement that occurs exceeding a yield tolerance of a tissue, so that's where the cells would rupture if they are moved too much, essentially is in that stratification of layers between tissue types. So if we look here, bone has a yield tolerance of up to around 2%, so any greater movement than 2% and bone cannot be formed, and then cartilage at 10%, granulation tissue at 100%. So there is always a tissue being made, but the type of tissue is dependent on the amount of movement that occurs at the fracture site, the strain. Here we see a pictorial representation of that. So the green is the fracture gap, and if you look at the fracture gap, the same size fracture gap in all three examples, the red is the amount of relative motion. Then the increasing relative motion leads to the different types of tissue being generated. Similarly, if we keep the motion the same and change the size of the fracture gap, we see different types of tissue being generated. So a big gap, small motion, we get bone because the change in length over the unit length, the strain formula, is favorable to the bone forming equation. Whereas if we have a small gap and an amount of movement that's the same, we have a relatively large amount of strain, then we see granulation tissue form because that's what the formula defines in terms of tissue genesis. But it isn't that simple because bones don't move just longitudinally. We also see bending moments and similar. So in an angular displacement, we may have differential strain on one side of the fracture to the other. And that's typical. If you look at plating constructs, you'll often see asymmetric callus. And so these slides show you what happens at a cellular level in this bone healing organ. We have a group of cells, and they are being subject to motion. The change in length over the original unit length is our strain formula. And if we have a small gap and a relatively large amount of motion, all of that motion is occurring over a few cells. Those cells rupture. They cannot tolerate that movement. If you have a large gap, that cellular population shares the strain and they don't rupture. They're able to continue to function. Clinically, what does that mean? Well, we can translate that into our ideas around fixation. Small gaps with compression give us absolute stability, so a very low strain environment, and we get healing. Okay, but we don't get callus, we get that direct primary bone healing. A small gap with no compression, and this is the typical simple fracture line fixed by a locked plate maybe where the fracture's not reduced perfectly, give us a gap and motion, but the gap is small, the motion is relatively large, we get high strain, poor healing. In comminuted fractures, the strain is shared more evenly across the fracture lines, so relatively they all have a low strain environment, and that leads to callus formation. So if we take this, and this is from the unified theory, the concept of a graph where we see bone healing on the vertical axis and strain on the other, you'll notice there are no units here because we don't really know the magic units. This is the zone, the Goldilocks zone, if you like, of where we're aiming for with our fracture fixations. And this is all summarized in this paper, and if you haven't read it, I would direct you to it because it really does take you through the mechanical journey of healing in terms of fractures and non-unions. And as I say, if you understand the concept with respect to non-union, you're able to apply much of that to your primary fixation constructs. And it's not new. This chap, Julius Wolff, recognized that bone responds to its mechanical environment. So we know that, and our compression and tension trabeculae and so on are laid down in response to the local mechanics. So there must be something that responds to the local mechanics, and indeed our osteoblasts and cells within the bone have mechanical receptor capability to orientate themselves. And similarly, the work of Lutz Klaus has shown us that it's not just compression that can reduce strain, but tension as well. So if we stretch a tissue, it will become stiffer and the strain will go down. And that has a bearing when it comes to us treating things later on. Furthermore, just to really reinforce the mechanical side of things, osteoblastic proliferation is dependent on local strain. So this graph here, and if you look, the most proliferation of osteoblasts occurs around the 1% strain mark. So if we achieve good quality strain in terms of what's needed for generating the tissues, not only do we see the right tissue being made, but we see a proliferation of osteoblasts in our fracture gap, and strain leads to osteoblasts orientating themselves in response to strain, whereas a no-strain environment leaves osteoblasts haphazard. They don't have a stimulus. They don't have direction. So just to wrap up, if we go back to that traditional teaching of these three types of non-union, and the really very different approaches to thinking about them in terms of treating them, depending on what you see on an X-ray, I'm not sure that fits, because there's an extra non-union that is missing. And if we understand the radiology of non-unions, and we go back to understanding how X-rays work, an X-ray is simply a photon that is impeded by the presence of a heavy atom, usually a metal ion, i.e. the calcium in bone. And if you look at the traditional teaching and we add in that extra non-union at the end, the pseudarthrosis, which is the most unstable of all non-unions, and we assume this now sits on a spectrum, and essentially what we're seeing here is a radiographic spectrum of non-union, from hypertrophic, where there's quite a lot of bone formation, all the way down to pseudarthrosis, where there's next to no bone formation. But the key thing I point out there is they are all making some sort of tissue in the gap. And there isn't an issue with the biology here. The issue here is that radiographically, you're not seeing bone formation. So for me, the concept of an atrophic non-union not having biology or it doesn't make sense, because if you continue on the spectrum, you get to pseudarthrosis next. And anyone who's operated on a pseudarthrosis will know that that's the most biologically alive thing you can find. The bone is so alive, it's formed its own new joint. So it must be healthy. So what we're seeing really is this spectrum of strain represented on X-rays, but we've misinterpreted that and labeled it in terms of their biology and therefore the need to intervene and treat. So for me, primarily the causes of non-union are mechanical much more than biological. I think the biology is always there, and there are examples in our practices where we've taken non-unions of many years' duration and simply adjusted the local mechanics, and they've gone on to heal. So they must still be able to have adequate biology after all of that time. There are, of course, theories, and I'm not taking away from the biological theory, but to me, I think the biology is always there. The mechanics is what drives my decision-making. And if we look at it in a little bit more detail, there's increasing work that's coming out looking at shear within bone, and shear is the biggest enemy that we have in orthopedics. From a mechanics point of view, it's the hardest bit to overcome. And that's because the deposition of appetite on collagen is dependent on local microenvironment, lots of local factors, hydrostatic pressures in the outside tissue matrix, etc. And shear gives us effectively the greatest amount of movement for the least amount of load in a fracture site. So it's kind of the non-union looking at that going, oh, lovely, there's shear, that's easy for me. All I need is a little bit of extra movement and then the thing won't heal, compared to in a transverse fracture. And we looked at this and we've mapped out a series of non-unions, and lo and behold, the majority of non-unions lie around the shear plane. So just to summarize, I think you need to try and understand, if you're managing non-union, how and why it failed. And actually, if you understand that, when it comes back full circle to you fixing acute fractures, you can really understand what you're trying to achieve. And actually, both for non-union and acute fractures, I hate the idea that we can have autopilot surgery. I always do this, I always do that. Look at each thing on its own merit and work out what the strategy and the solution is. And just as a final word, just beware of this guy, okay? An awful lot of the literature is going to tell you that if you sprinkle a bit of dust inside a rat's femur, it will magically heal. But let's not forget that rats aren't humans, the last time I checked. So to finish, the causes, and that's the treatment of non-union and bone healing, to me, revolve primarily around the mechanical environment. And I leave you with the final words, I think, or not, because it stopped. Well, I will leave it there then. The final slide. So mechanics is what matters. Thank you.